Welcome to Frankly Speaking About Family Medicine, a CME podcast series where each week we translate today's late-breaking clinical research and news into tomorrow's practice. I'm Frank Domino, professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School and editor-in-chief of the 5-Minute Clinical Consult series. Be sure to visit pri-med.com/podcast after the discussion for more information about today's article and to claim CME CE credit.
Joanne, a 37-year-old healthy patient, presents today with complaints of low-grade fever, cough, and congestion. She is sure she has bronchitis because she can feel it in her chest. Her previous provider always gave her an antibiotic to help clear it up. On exam, you note that she's in no distress, and she has a fever to 100.5. She has some nasal congestion, and her lung exam shows some coarse upper airway sounds, but no rales. You diagnose a viral URI and consider how best to help our patient understand she doesn't need an antibiotic. Hi, this is Frank Domino, and joining me today is Dr. Robert Baldor, professor and the founding chairman from the Department of Family Medicine at UMass Medical School, Baystate in Springfield, Massachusetts. Good morning, Bob.
Morning, Frank. It's always a pleasure to be talking about this topic.
It's great to have you back on the podcast, Bob. We've talked in the past about the evidence for shorter courses of antibiotics to treat bacterial infections, such as our podcasts on strep throat. I work hard to avoid overprescribing antibiotics, especially when a patient most likely has a viral syndrome. What's the latest data on how to address this topic with our patient Joanne?
Yeah, what I really like about this review is they actually gave us some data here, and they looked at people with comorbid conditions, looked at children, and so on. So basically, if we really think about this, I mean, we're trying to reduce unnecessary, inappropriate use of antibiotics. I mean, it's crucial to helping to address this antimicrobial resistance we're seeing. And most antibiotics are prescribed by primary care providers. That's where the action is here. So what this group did is they reviewed actually individual patient data from randomized controlled trials and some observational studies that were held in community settings. And they looked at strategies. And the first strategy was delaying antibiotic prescribing, which means you actually prescribe the antibiotic, but advise the patient not to start taking it unless they got worse or failed to improve after a day or two. Or a watchful waiting approach, which was basically observing for a set period of time to see if there's spontaneous symptom resolution before prescribing the antibiotic, or no antibiotics at all, or immediate antibiotics. So it's really interesting what they were looking at in these studies. So they analyzed data from 9 randomized controlled trials and 4 observational studies from, again, primary care settings, although this did include 1 pediatric ER setting. And this was a total of over 50, almost 55,600 patients. And these studies were conducted in the United States, United Kingdom, New Zealand, Spain, and one study was a multi-European study. What's cool about this is the database, and it was broken down by age. And this was children 0 to 4, 5 to 15, adults 6 to 16, or greater than 65 years of age. They looked at whether fever was present or not, and they characterized fever being present as if you had a temperature of greater than 37.5 degrees centigrade, which is 99.5 Fahrenheit. They looked at the conditions, which included sore throat, cough, chest infection, otitis media, upper respiratory tract infection. They looked at the duration and the severity of the illness. They looked for differences related to sex, but also they looked at smoking status, whether people had underlying lung diseases, asthma, COPD, or other comorbid conditions such as heart disease and diabetes. So really a very comprehensive look at people coming in with all kinds of conditions here. The primary outcome of interest was the average symptom severity, and they called this, they used a scale, 6-point scale, and this was kind of cool: normal, very little problem, slight problem, moderately bad, bad, or very bad, or as bad as could be. So I kind of like that scale that they used there. And they looked at this. They were looking at that outcome 2 to 4 days after the initial consultation. Secondary outcomes that they looked at then were the duration of the illness after that initial consultation, complications resulting in admission to the hospital or death, reconsultation for the same or worsening illness. And they also looked at patient satisfaction, and that was rated on a Likert scale.
Wow, I would definitely say this was comprehensive. I love the four treatment approaches that they analyze: the delayed antibiotic, watchful waiting, no antibiotic, or immediate antibiotic. They've done a great job stratifying by both age, gender, and comorbidity. And they did a very nice job of looking at the secondary outcomes, including everything from death to patient satisfaction. So, what were the conclusions of the study? What did they find?
Yeah, I just say really an interesting publication and study here. They looked at several outcomes. So let's start with severity. So first, they looked at severity as an outcome, and overall, no significant difference in symptoms severity between delaying antibiotics and no antibiotics or immediate antibiotics. Although interestingly enough, children less than 5 years of age had a slightly higher follow-up symptom severity score with delayed versus immediate antibiotics. So there was a little difference there in treating young children. Now, time to symptom resolution also, though, was slightly longer with delayed antibiotics versus giving immediate antibiotics. But get this, Frank, it was only a half a day longer. And if you immediately gave antibiotics, symptom resolution on average, 10.9 days. Now, if you delayed the antibiotic, it was 11.4 days. So really, in my mind, not clinically an issue here. Now, perhaps not surprisingly, reconsultation rates were lower with delayed versus no antibiotics, but this was 17% of people who didn't get antibiotics came back in for reconsultation. Those with delayed, 13%, but this was not actually statistically significant if you looked at these. But I really worry about things like complications, right? That's what we worry about, is missing something by not giving antibiotics right away. And complications resulting in hospital admission or deaths were actually lower with lower than with the delayed antibiotics versus no antibiotics. And I'm assuming this probably relates to side effects from that. But interesting, not quite clear. They were interesting lower and delayed than immediate antibiotics, but neither result was significantly significant. I'm actually going to restate that. Let me re-say that. Um, of course, the thing I worry about is complications, that you're missing something and somebody really gets a lot sicker because I didn't give them an antibiotic. So they looked at this, and complications resulting in hospital admission or death were lower with delayed than with no antibiotics. And interestingly, lower and delayed than immediate antibiotics. And that I'm assuming, was because if you're giving an antibiotic immediately, you're more likely to run into potential side effects from the antibiotic, and that's why you saw this with a delayed repost. Turns out, though, neither of those approaches were statistically significant. So the delay was certainly did not create more problems versus giving an antibiotic immediately. It may have been a little better. They looked at patient satisfaction. This is a key piece, I think, of what we're doing today. So much of, what are patients thinking about how we're treating them and what we're doing? We're being rated on this more and more. Patient satisfaction was actually higher with delayed than with no antibiotics. And of course, you can imagine that, but not by a very small difference. If you didn't give antibiotics, patient satisfaction rating was 2.96. If you used the delayed approach, it was 3.04 points on their Likert scale.
Okay, so this is really helpful. It turns out delaying antibiotics, if anything, has the potential to lower adverse events, including hospitalization and death, and may actually improve patient satisfaction score. It makes perfect sense. It sounds like the data is really supportive of the delayed prescription method. Did they make any final conclusions that we can start applying in clinical practice?
Yeah, I mean, their general conclusions were pretty much right on what you just said here. They concluded that delayed prescribing, and again, this is actually prescribing an antibiotic to the patient, but advising the patient not start taking it unless their condition got worse or failed to improve after a couple of days, appears to be safe and effective strategy for most patients, including those at higher risk subgroups. And again, whenever I'm seeing somebody with COPD or diabetic, I'm thinking, oh, maybe I should be throwing an antibiotic in there earlier. That they're saying no. And compared with no prescription approach, delayed prescribing appears to reduce reconsultation rates and is associated with slightly higher levels of patient satisfaction. Now, Compared to the immediate antibiotics, which is really, I think, what a lot of us is looking at, delaying the prescription did not result in higher complication rates. If anything, they are lower, does not significantly decrease patient satisfaction. So I consider such approach for your patient, Joanne. I'd also explain in simple, clear language the self-limiting nature of most respiratory tract infections. But mind you, this is 10 days. Whether you're on an antibiotic or not, it's 10 days. So I think it's important to advise people that the natural course of these things is about 10 days. I've actually working hard on this, and what I've been saying to patients is it's a little bit similar to this, but I don't actually prescribe the antibiotic. I'll say to the patient, look, I think that this condition is viral and antibiotics not really going to help you. In fact, you may have side effects from taking an antibiotic. Why don't we wait and see what's going to happen here over the next couple of days? If you're worse over the next couple, give me a call back, and then I'll send an antibiotic in for you to take. But by the way, this is probably going to be 10 days before you're really better, regardless of what we do. And I think I've had pretty good response to that.
Bob, I do just about the same thing. I don't mind giving the patients a paper and a prescription and just say, hang on to it. Let's talk in 48 to 72 hours. And if things are getting worse, then we'll think about going ahead and starting it. The other thing I do, I try not to diss their previous provider. And I say, listen, the guidelines used to encourage us to use antibiotics more and more, but things have changed because we've caused so many adverse problems like C. difficile and methicillin-resistant staph. And when I say those two words, patients' ears perk up. They're like, oh, I don't want to get those things. So say, look, let's just reconnect in a few days. And if you're not getting better, then we'll go ahead and start the antibiotics. And you're absolutely right. Something I'm going to fully incorporate is to say, look, it takes 10 to 14 days for these sorts of infections to fully resolve. So be patient. And certainly if you get worse, let me know right away. And please keep in touch. Bob, this is a great paper. It's practice changing. Thanks so much.
Yeah, Frank, I do want to comment. I love what you just say there. Be careful not to diss the previous provider. And I love the way you couch this. And yeah, things have changed because we're aware of MRSA and C. difficile. That's wonderful. I hadn't thought of that. And I'm going to incorporate that myself. Thanks a lot for those suggestions.
Thanks, Bob. Practice pointer. Consider a delay in prescribing an antibiotic to treat most respiratory complaints presenting in the primary care setting. Join us next time when we talk about the influence of trauma informing your day-to-day care of all of our patients.
Thank you for listening to Frankly Speaking About Family Medicine, brought to you by Pri-Med. To claim credit and receive additional information about the article referenced in today's episode, visit primed.com/podcast, and see you next week.